Hello everyone and welcome to Blood and Hematology YouTube channel. This video is about iron deficiency anemia. Iron deficiency anemia is the most common nutritional deficiency in both developing and developed countries. Approximately 25% of people worldwide have anemia. Iron deficiency, the most common cause, is responsible for 50% of all anemias. Iron deficiency anemia may be defined by cutoff hemoglobin values of 12.1 gram per deciliter in women and 13.8 gram per deciliter in men at or near sea level, with higher cutoff values at high altitude. Iron deficiency occurs as a late manifestation of prolonged negative iron balance, as a result of decreased iron intake, decreased absorption, chronic blood loss or increased systemic requirements. The cause of iron deficiency anemia varies based on age, gender, and socioeconomic status. Iron is distributed among three compartments. The storage compartment is the iron that is not currently functioning but is available when needed. The major sources of this stored iron are the macrophages and hepatocytes, but every cell, except mature red blood cells, stores some iron. The second compartment is the transport compartment of iron, that is in transit from one body site to another in the plasma. The functional compartment contains all iron that is functioning within cells. Though most of this is the iron in hemoglobin, the iron in myoglobin and cytochromes. Three pathogenic factors are implicated in the anemia of iron deficiency. First, hemoglobin synthesis is impaired as a consequence of reduced iron supply. Second, there is a generalized defect in cellular proliferation. And third, survival of erythroid precursors and erythrocytes is reduced, particularly when the anemia is severe. Iron deficiency anemia develops slowly and in sequential stages over a period of negative iron balance. These stages are commonly referred to as iron depletion, iron deficient erythropoiesis, and iron deficiency anemia. Laboratory evaluation of iron status and complete blood count are helpful in defining three stages of iron deficiency anemia. Stage 1 of iron deficiency is characterized by a progressive loss of storage iron, without reduced serum iron levels. Serum ferritin levels are low, which indicates the decline in stored iron, and this also could be detected in an iron stain of the bone marrow. Erythrocyte development is normal, because the body reserve of iron is sufficient to maintain the transport and functional compartments through this phase. There is no evidence of iron deficiency in the peripheral blood, because erythrocytes survive 120 days, and the patient does not experience symptoms of anemia. The second stage of iron deficiency is defined by iron-deficient erythropoiesis and the exhaustion of the storage pool of iron. Prussian blue stain of the bone marrow in stage 2 shows essentially no stored iron and sideroblasts. The serum iron, serum ferritin and transferrin saturation levels decrease, whereas total iron binding capacity increases. Transferrin receptors increase on the surface of iron-starved cells as they try to capture as much available iron as possible. They also are shed into the plasma, so the soluble transferrin receptor levels increase measurably. Free erythrocyte protoporphyrin and zinc protoporphyrin begin to accumulate. The hemoglobin content of reticulocytes begins to decrease, which reflects the onset of iron-deficient erythropoiesis, but the overall hemoglobin measurement is still normal. The mean cell volume usually remains within normal limits, but a few microcytes may be detected on a blood smear. The red cell distribution width may begin increasing, as some smaller erythrocytes are released from the bone marrow. In the third stage, all laboratory tests for iron status become markedly abnormal. The blood hemoglobin concentration falls below the lower limit of normal, and iron deficiency anemia is apparent. The most significant finding is the classic microcytic hyperchromic anemia. The tests for iron deficiency can be grouped into three general categories: screening, diagnostic, and specialized. When iron-deficient erythropoiesis is underway, the complete blood count results begin to show evidence of anisocytosis, microcytosis, and hyperchromia. The classic picture of iron deficiency anemia in stage 3 includes a decreased hemoglobin level and the red cell distribution width greater than 15%. Iron studies remain the backbone for diagnosis of iron deficiency. Other tests, although not commonly used for the diagnosis of iron deficiency, show abnormalities that become important in the differential diagnosis of similar conditions. The earliest evidence of iron deficiency is an increase in the red cell distribution width. This is indicative of the anisocytosis that precedes anemia. The next change observed is a fall in the hemoglobin, red blood cell count and hematocrit. The mean cell volume and mean cell hemoglobin values are reduced in most patients, and the mean cell hemoglobin concentration is reduced in long-standing or severe disease. The degree of change in the red cell indices is related in part to the duration and in part to the severity of the anemia. In mild iron deficiency of short duration, the indices may be within normal ranges. The reticulocyte percentage may be normal or elevated, while the absolute reticulocyte count is normal or reduced. A low reticulocyte hemoglobin content is an early sign of iron deficiency and precedes any fall in hemoglobin, MCH, or MCV. Thrombocytosis may be present, particularly if the iron deficiency results from chronic bleeding, but this is not a diagnostic parameter. The leukocytes are usually normal in number and appearance, but mild granulocytopenia may occur in long-standing cases of iron deficiency. Because iron deficiency develops progressively, any gradation between normal blood picture and the well-developed microcytic hyperchromic iron deficient can occur. In iron deficiency, anormocytic normochromic anemia with anisocytosis precedes the development of anisochromasia, hyperchromia, and microcytosis. Anisocytosis is an important early sign in iron deficiency and has differential diagnostic value when quantified. Poikilocytosis, including occasional target cells, elliptocytes, pencil cells, tiny microcytes and teardrop cells may be present, although no particular shape is characteristic or predominant. Basophilic stippling and polychromasia are sometimes present, although they are not prominent findings. The typical blood picture can be masked if the iron-deficient patient has a concurrent vitamin B12 or folate deficiency. In these cases, microcytosis can become apparent only after vitamin B12 or folic acid replacement therapy. Case number 1. A 3-year-old boy with moderate iron deficiency anemia. The peripheral blood film showing anisocytosis, hyperchromia, microcytosis, poikilocytosis, pencil cells, elliptocytes, and target cells. Case number 2. A 37-year-old female with moderate iron deficiency anemia. The peripheral blood film showing anisocytosis, few elliptocytes, hyperchromia, and microcytosis. Note the variation in erythrocytes' diameters compared to the lymphocytes' nuclear diameter. Case number 3. A 70-year-old female with moderate iron deficiency anemia. The peripheral blood film showing anisocytosis, poikilocytosis, hyperchromia, and microcytosis. Case number 4. A 46-year-old female with moderate iron deficiency anemia. The peripheral blood film showing anisocytosis, hyperchromia, microcytosis, and elliptocytes. Case number 5. A 16-year-old female with moderate iron deficiency anemia. The peripheral blood film showing anisocytosis, few elliptocytes, hyperchromia, and microcytosis. Case number 6. A 12-year-old boy with severe iron deficiency anemia. The peripheral blood film showing anisocytosis, hyperchromia, microcytosis, elliptocytes, and target cells. Case number 7. A 70-year-old female with severe iron deficiency anemia. The peripheral blood film from a patient with cold agglutinin hemolytic anemia, showing erythrocyte agglutination, anisocytosis, hyperchromia, and microcytosis. Evaluation of iron stores using serum iron studies eliminates the need for bone marrow examination in almost all iron deficiency anemia cases. The bone marrow shows mild to moderate erythroid hyperplasia with a decreased myeloid to erythroid ratio. Total cellularity is often moderately increased. Erythroid nuclear abnormalities are sometimes present. Stains for iron reveal an absence of hemosiderin in the macrophages. Sideroblasts are markedly reduced or absent. The important differential diagnosis of iron deficiency anemia are thalassemia trait and the anemia of chronic disease. The blood film and count are of some use in distinguishing these disorders, but specific tests are needed for a precise diagnosis. Thank you for watching this video. If you liked this video, to give it a thumbs up and share it. Do not forget to subscribe to the channel, if you still have not. You can click on the bell to receive notifications whenever a new video is uploaded.